Welcome everybody. It's really good to see so many people joining us today on this open session for vets on top tips on clinical immunology. So thank you all very much. Before we start, I want to let everybody know that this session is being recorded. Please also keep an eye on the chat box, because that is where we will send a link for you to register your attendance and receive your certificate at the end of this session. So my name is Katie Ebbs, and I am the program tutor for the Small Animal Medicine Distance Learning Program here at Improve International. With me tonight, I have Alison Babington, Business Development and Digital Learning Coordinator, Kate Costaris, Digital Learning Coordinator, and James Swann, who is a specialist in internal medicine. This evening, we're going to start with an overview on Small Animal Medicine Distance Learning Program, including a quick demonstration of one of the interactive lessons. And then after this, we will turn our attention to James Swann, one of the authors for the Small Animal Medicine Program, and he will share his knowledge on immunology. So we will be taking questions via the chat box at the end of the session. So there will be an opportunity for you to ask us questions about the SAM program and ask James about immunology. So you can use the menu shown on the horizontal bar to send your questions to us. A link will be added to the chat box for you to follow to enter your email and receive your CPD certificate after the session. You can also leave your email address by scanning the QR code, which will be provided on the last slide of James's presentation. So I'm going to hand over to the lovely Alison, who's going to give you a brief overview of Improve International. Thank you very much.
Thank you, Katie, and good evening, everybody. Some of you will be familiar with Improve, but for those of you who aren't, we thought it would be good to just introduce ourselves quickly. Improve has been providing CPD to veterinary professionals globally for over 20 years and was the originator of modular CPD. We are continually adapting and innovating our teaching and learning, from face-to-face lectures and practical training to the more recent DL programs. We are truly a global company, offering CPD to countries as far as Japan, USA, Australia, and many of the European countries. In 2020, we delivered over 400 different CPD courses, providing over 1,000 days of training to the profession. Improve was created by a group of vets passionate about delivering high-quality continuous education. And this is still the case today. By studying with us, you will take back to practice new skills, enthusiasm, and confidence to handle those challenging clinical scenarios. Our programs are accredited by ISVPS and validated by Harper Adams University. Throughout the program, you can work towards a recognized qualification. This might be the GP Cert awarded by ISVPS, who have already globally awarded more than 5,000 GP certs. Or by completing additional assignments, you can achieve the PGC award from Harper Adams University. The PGC is Small Animal Medicine is a recognised eligible entry qualification for advanced practitioner with the RCVS. Thank you for listening, and I'm now going to pass to Kate Costaris, who's going to give you a brief overview of the Small Animal Medicine Distance Learning Programme, including a short demonstration on our learning management platform. Thank you.
Thanks, Alison. Evening, everyone. So I'm just going to give you a little bit of a rundown about what our distance learning programs are. Now, effectively, we all know how it is, busy practice, you've got no time in the evenings, the kids are everywhere, running riot, and there's no time to take that day off to go and actually do the CPD and go off for the day. And this is where the distance learning programs are brilliant, because they enable you to do the CPD in your own time, at your own pace, in the comfort of your own home. So it's really easy to fit around family life or a busy practice setting. So the content that is included in the distance learning programs is all developed by veterinary specialists, and it's hosted on our world leading platform. You're supported the whole time throughout your journey through the courses by a module tutor who is a specialist in their field. So this means you've got access to a discussion forum where you can chat about the lessons that you've done online with them, or ask some questions about some of your cases and things like that. And the lessons, which we'll chat about a bit more in a moment, are not only kind of a boring text to read through, they're actually created to be really visual, really interactive, and a fun learning style with quizzes and sort of check and chunk activities the whole way through. And being online, as I said, it's just great that you can fit your studies into your practice commitments, so it's easier to achieve that important work-life balance. Now, the small animal medicine course in particular runs twice a year. So it starts usually on the 1st of January each year, sorry, 3 times a year, with an extra intake in June and September. So for example, if you joined in June, you'd be finishing the course in May 2023. So there's 20 modules and it's spread over 2 years. But don't worry, you get a month off in August for a summer holiday and a month off in December for Christmas holidays. So it gives you a chance just to take a little breather, catch up on anything, any extra reading and bits like that as well. And all the modules, which obviously there's a lot more information on our website, but it covers everything from clinical pathology to cardiology, emergency and critical care, endocrinology, everything's in there. And you can see all of the learning objectives for all of those and which specialists are running them on the website. 16 different specialists actually have contributed to the program, and they've brought with them a really vast range of experience in their own areas. Now, each module is a month long, so it's a module a month, and it consists of a little pre and post module sort of assessment, which consists of sort of multiple choice questions to check your knowledge before you begin the course and afterwards. So it allows you to see how much you've learnt and gauge the level you're at beforehand and afterwards. There's 9 lessons in each module and 2 case studies, as well as having a recommended reading list, a PDF version of the notes that you can take into practice in a folder with you, and introduction and summary videos from the module tutors, just really summarising the key information that you should take home with you. So what I'm going to do in a moment is just share a screen with you and go through one of the lessons to show you what it looks like. So if you bear with me one moment. Here we go. So here we are in the module for Gastroenterology 1. And as you can see, this is the layout that you'll see for each module. So it's really easy to navigate and follow. We've got the module introduction, which is from a little video from the module tutor, so the specialist. And then it's split up into the 3 weeks here, each containing 3 lessons, 2 case studies, which really draw together all that knowledge and test it in real life scenarios. The recommended reading list and the ever important discussion forum. Great chance to connect with your peers, find people who are like-minded and have similar interests, as well as being able to discuss your cases and all that information with the specialist as well during that month. So it's really, really a fantastic resource to have. So if we delve a little bit closer into one of the lessons in particular, I've popped into one that's called esophageal disorders. So effectively, this is how the lessons are laid out. And it's absolutely brilliant because down the side, you've got the contents page. You can see what's coming up, but you have to complete it in order. So you can't actually skip ahead. It forces you to do every little section. But actually what's brilliant is, as you can see here, I am 25% through this lesson, but I can straight away click to where I left off. So this is absolutely invaluable. If you have a spare moment in the middle of the day, say you're at work and you're at lunch, you can just pop onto this on any kind of device on your laptop, sneak on, carry on, do sort of one of the subsections and come back to it later. So you don't have to complete the entire lesson in one go. You can do little bite-sized chunks as you go. And we'll just have a little bit of a scroll through to show you what's involved in one of the lessons. So here we've got the kind of introduction, we've got a little audio clip from Scott. It tells you what your learning objectives are, and then you can follow through the lesson. So obviously we have to have the mix of text for you to read through, and then we always have these checking and chunking questions and interactivities. And these vary. So I'll just sneak forwards a little bit. We have labeling of images, true false quizzes, all sorts of things. And if you've ever done Duolingo and tried to learn a language, which I have, it's kind of based on that sort of idea that rather than rote learning and reading, you've actually got these interactivities and almost games to play. So for example, here we've got to drag and drop to the correct answer. And if it's incorrect, we'll get a little shake and it won't allow us to do it. And you can just carry on until you've completed them all. And then we've got multiple choice questions, so you can select the right answer from the list. And then, for example, once you've ticked it, it will actually demo which ones were correct and which were incorrect. So you get that automatic feedback as well, and you can opt to take it again. So it's actually brilliant for revision purposes because you can go back through the lessons and see if you can answer all of those correctly. And then finally, we'll just show we've got the little drag and drop options where you can drag words into the correct places and then click check to see if you've done them correctly. So it's a really valuable and brilliant platform to learn. I myself did a certificate in small animal medicine with Improve back when it was a face-to-face session. And for me, just the fact that this can be done from the comfort of your own home and your CPD is sort of planned out for you. So you're doing it and you're working towards a qualification is absolutely brilliant. So obviously, if you've got any questions about that, then please do pop them in the chat box and we can answer them. But without further ado, it is time to pass over to James. I know you were waiting for his immunology presentation. So we'll pass over to him, but please do ask any questions, whether it be about the course itself or for James as we go.
Thank you. I'll just share my slides. Great. So today I'm just planning to share a few top tips in clinical immunology, and these are the kind of things which often come up in the discussion forum in the immunology module, which Kate was just referring to. So as well as having all of the planned teaching, there's the opportunity to ask questions and bring up clinical cases in the forum during the whole month that each module runs. And so I've just taken a selection of topics which often come up when we run the immunology module, just to show you the kind of things that we often end up talking about. So if we start first of all with this topic of diagnosing IMHA, so I'm sure that everybody has seen cases of IMHA, either that you've diagnosed yourself or which have come into the practice and generally a big deal because everybody's very worried about how they're doing. So if we just consider this case of a 4-year-old female neutered Springer Spaniel with a 2-week history of lethargy that has then acutely collapsed while running, and this would be a really typical presentation for a case with IMHA. And so a sensible first step is seeing a case like this that has the typical pallor would be to look at some measure of how anemic they might be. So in this case, a PCV of 21% and a normal total protein. But then comes a more difficult question, which is how do we try and rule in or out a diagnosis of IMHA to an extent that we would then feel confident about introducing immunosuppressive treatment. And so a test that we often reach for in the clinic is this saline agglutination test. The problem is that there's a great deal of variation in how you can do this test and how you can interpret it. So here is an example at the bottom left of macroscopic agglutination. So this is just mixing 1 drop of blood with 1 drop of saline on a glass slide and then looking for this gross agglutination. And on the bottom right is an example of microscopic agglutination, which is really doing a very similar thing, but then looking under a microscope for evidence of these large aggregates of red blood cells, which indicates that there are antibodies which are causing agglutination of red blood cells, which is part of the pathogenesis of IMHA. The problem is that everybody seems to do this test in a different way. So some people, as I say, will use 1 drop of saline and 1 drop of blood. Other people will use 10 drops of saline and 1 drop of blood. Some people will wash the red blood cells, by which I mean that they'll put the blood in a tube, spin it down, remove the serum, add some saline, wash the red blood cells, spin it down again, remove the saline, and then do the test. So in that way, you've got rid of all of the patient's original serum, and you're just looking at whether there are antibodies on the red blood cell surface. And then there's this question of, should you bother doing the microscopic? I would say when I worked in practice, then we never did the microscopic. We just looked at the macroscopic and left it at that. And there has been some recent information to try and help with all of these decisions. So a study that was published just last year tried to look at the effect that the extent of saline dilution had on the performance of this test. So what they did was they took lots of patients with anemia, some of which had IMHA, some of which had other causes for anemia, and they did this test with different ratios of saline and blood. So first of all, they just did 1 drop of blood with 1 drop of saline, then they did 1 drop of blood with 4 drops or 9 drops or 49 drops of saline, and then they evaluated the microscopic agglutination as shown in the picture here. And what they found was that as they increased the dilution of saline, then the specificity of the test became higher. And specificity means what's the likelihood that a dog that definitely doesn't have the disease yields a negative test. And as you can see here, as you dilute the blood to a greater extent, you're much more confident that a negative test is correct, that if you have no agglutination seen on the slide, that dog does definitely not have IMHA. And the sensitivity remains quite high also. So sensitivity is the likelihood that a dog that does have the condition yields a positive test. And as you can see here, as you dilute the saline progressively, you still have a very high proportion of dogs which are giving a positive result. But what's really important here is that if you look at the 1-to-1 ratio of saline and blood, the specificity is very low, at 32%. And this means that a lot of dogs that don't have IMHA are giving a positive result with a 1-to-1 ratio of saline and blood, which means that if we just do that very simple test of mixing 1 drop of saline and 1 drop of blood on a slide, it's possible that we would misdiagnose some dogs that have a different cause of anemia with IMHA. And so the conclusion from this study is that if we dilute the blood to a much greater extent, so in the region of 50 drops of saline to 1 drop of blood, then we would have a much higher specificity, meaning that if we have a negative test, we're sure that's not IMHA, but we still have a high sensitivity, meaning that the majority of dogs with IMHA will still yield a positive result. How would you actually do that in practice? So we couldn't do that on a slide, 49 drops of saline and 1 drop of blood. It's something really that needs to be done in a tube. So if you have the small 1.5 ml tubes that you might use for urine sediment examination, it would be possible to dilute the blood to that extent, then transfer a small amount of that onto a glass slide and look under the microscope for evidence of those aggregates of more than 4 red blood cells all at the same time. And especially, as I say, if you have a dog that doesn't have any of the classic features of IMHA, so for example, if it didn't present in the way that I described this case, if it had a longer history of being unwell, or if it wasn't particularly anemic, then I'd really recommend thinking about doing this, because it will improve the performance of the confidence in the test results. So in this case, which I'm describing here, then it did have a positive saline agglutination test done in this way with a higher specificity. And then a second question that we often think about asking is there some underlying cause which is causing this IMHA? So as we all know, many cases of IMHA are primary, meaning that they just happen for no reason that we really understand fully. It's probably a mixture of environmental risk factors and some genetic underlying factors. But also in many cases, about 20 to 30% of them will have some underlying issue like cancer, especially lymphoma, depending on where you work, sometimes infectious diseases. So for example, in Southern Europe or in the States, various tick-borne infections have been associated with IMHA. And in the UK, in the last couple of years, there have been outbreaks of babesiosis in dogs that had not travelled abroad, which suggests that at least in the southeast of England, then there might be possibility of having exposure to babesia that causes very similar symptoms to IMHA. And it's also been associated sometimes with other infections. So for example, pyelonephritis or severe gastrointestinal infections have occasionally seemed to be associated with IMHA. And so a question that often arises is, what tests should we do to try and exclude some underlying cause? The answer really is as long as a piece of string, because if you did all of these tests, then it's possible that you might find something. And what we really want is an approach which is based on evidence and which would capture the majority of cases that do have an underlying cause. So a common approach which is taken is for people to do a CBC and biochemistry that would probably be done anyway as part of the initial investigation, to do abdominal and thoracic imaging to look for things like masses, migrating foreign bodies, inflammatory lesions like abscesses or granulomas. We'd often think about doing urinalysis because it has been associated with pyelonephritis. So if there is a positive urinary tract infection, it could be suspicious and certainly would probably require treatment. And then infectious disease testing, which is appropriate to the region in which the dog is presented. So if it's presented in an area where there really aren't any endemic agents, then the importance of that is much lower. But then there are some people that would suggest that perhaps we should be doing more extensive investigations. So for example, because lymphoma is a common underlying cause of IMHA, should we be doing aspirates of the lymph nodes and the liver and the spleen in all of these cases that are presented? Again, there's been some recent information that helps us with this decision, which was a study of around 75 dogs where the authors went back and looked at the results of the diagnostic imaging that was done. So all of these dogs did have thoracic radiographs and abdominal ultrasound performed. And it actually turned out that more than 2/3 of those, the thoracic radiographs, were just completely normal, and in about a quarter the abdominal ultrasound was also normal. They then asked if there was an abnormality, was it important for the treatment of the dog? Because as we know, you will often find incidental findings on imaging. So let's say, for example, that they saw some evidence of gallbladder sludge, which as we know is a very common finding on abdominal ultrasounds, but probably not relevant to the condition being investigated or treated. And then when they applied that standard, they found that 3/4 of thoracic radiographs were not useful and 50% of abdominal ultrasounds were not useful either. And so this makes us think that perhaps we don't need to be quite so dogmatic in our recommendations about investigating IMHA, because we know that the majority are not going to have probably any thoracic pathology that we need to think about. And so an approach that is much more pragmatic and which many people are perhaps adopting in practice anyway is just to be pragmatic and think, what are the risks for this individual patient? So if it's a relatively young 2 to 3 year old dog of a breed which we know is at high risk of IMHA, like a Cocker Spaniel or a Springer Spaniel, then I would say that the necessity for diagnostic imaging is much lower. And especially if costs are limited, then it may be something that we would feel relatively confident in not doing if that was discussed with the owner thoroughly. However, if it's a 12-year-old dog of a breed that isn't particularly predisposed to IMHA, then I would feel that the abdominal imaging and perhaps also thoracic imaging would be of much greater importance to make sure that this wouldn't be a case that had underlying neoplasia. And this is something that we're trying to investigate further actually at the moment by doing some research of asking if we basically have a sort of algorithm where we say, how old is this dog, therefore what tests will we do? Is that a sensible approach so that we can limit the number of unnecessary investigations but still detect those secondary cases of IMHA that probably require different treatment? So just to move on, a second aspect that we often talk about is about optimizing glucocorticoid treatment. So as everybody knows, almost all dogs with IMHA will be treated with glucocorticoids, usually oral prednisolone, or if they won't tolerate oral treatment initially, they're often treated with dexamethasone while they're in the hospital. And this is the kind of thing where you'd think that we'd be pretty good at doing this because glucocorticoids have been administered for more than 50 years in dogs for treatment of various immune-mediated or allergic conditions. But actually, there's often just some small changes that we can do that will limit glucocorticoid side effects and make them as effective as possible. And some of the questions, the simple questions that we might ask are, let's say in this particular dog that weighs about 10 kilos and we want to start on treatment, what frequency of treatment should we give? So should we be using once daily treatment, twice daily treatment, or does it matter? What time of day should we be giving the treatment? So should it be morning, evening, or again, not going to make any difference? And if this dog was much heavier, so if it was a 30-kilo dog as opposed to a 10-kilo one, would we adjust our approach to treatment in any way at all? We asked people in practice what they were doing. So in the same situation as the case that I've described of a newly diagnosed dog with IMHA that was going to be started on treatment, we asked what initial dose of prednisolone would you give after that initial diagnosis. And as you can see here, the vast majority of people would give a dose of 2 mg per kg per day. But some people are giving much higher doses, as you can see here, so up to kind of 4 or 6, or even in one extreme case, up to 9 or 10 mg per kg per day. And some people actually giving quite a bit less, so in the region of 1 to 1.5 mg per kg per day. And so what does the evidence tell us about this? So we know that probably the most effective immunosuppressive dose of prednisolone is in this region of 2 to 3 mg per kg, by which I mean that if you go above that level, we don't really see any additional increase in immunosuppression. So from a therapeutic point of view, we're probably not achieving much more in terms of disease control by going above 2 to 3 mg per kg, which is why that dose is the one that you would find in most formularies. But what we do know, at least from human evidence, and we have some suggestion of this in dogs as well, is that the risk of adverse effects is strongly associated with the dose rate that's being given. So here, for example, is the odds of vertebral fracture in people, because they often will develop osteoporosis while they're on treatment with prednisolone. And as you can see here, as the dose of prednisolone increases on the x-axis, the likelihood of the vertebral fracture increases on the y-axis. And this is actually an exponential relationship because this y-axis is on a log scale. And then similarly, the risk of lipodystrophy, which we would call pot belly in dogs, is also associated with the dosage of prednisolone that's being given. And there's a bit of evidence to suggest that we might need to take this into account with weight in dogs. So we would frequently dose on a mg per kg basis. So as I say, the standard recommendation has always been 2 mg per kg. But actually, this evidence published a few years ago suggests actually that may not be appropriate according to the size of the dog in question. So what's shown in this figure is if you first of all look at the blue line, that's a dose of 2 mg per kg in a small breed dog less than 20 kilos. On the y-axis is the concentration of prednisolone in the blood, and on the x-axis is the time after administration of prednisolone. So you can see that there's a peak within 1 to 2 hours after administering prednisolone, and then it tapers off gradually after that. The red line then shows the same dosage, 2 mg per kg, in a large breed dog, more than 20 kilos. And you might think beforehand that would just achieve the same level in the blood, but as you can see, the level is a great deal higher, so that the blood concentration is going up to a much higher extent. However, if you dose the same size dogs based on surface area rather than weight, you can see actually that you achieve a similar pharmacokinetic profile to 2 mg per kg in a small breed dog. And that, I think, presents fairly good evidence that we should perhaps be dosing larger dogs based on surface area rather than total body weight. It would be quite possible to dose all dogs on 40 mg per meter squared. So if you work out 40 mg per meter squared in a small dog, it is roughly 2 mg per kg anyway. But once you get above 20 kilos, then the mg per kg and the mg per meter squared start to become very different. And I think that fits in with the kind of anecdotal suggestion that a lot of people have reported that it's the large breed dogs which often have the most noticeable side effects with prednisolone. So then this question on dose frequency. So again, does it make any difference if you dose either once daily or twice daily? And this is something that we looked into where we took dogs with first diagnosed with IMHA, and we randomized them to get prednisolone either once daily or twice daily. So these dogs were getting the same total dose per day, but in half of them, we split it just into 2 doses, morning and evening. In the other half, we just gave it all as one big dose in the morning. And then we looked at the outcome of those dogs in terms of the number that survived, their blood test parameters, and also we asked the owners to tell us about their quality of life by giving them a questionnaire on multiple occasions to ask them how they thought the dogs were getting on. And this was one of the most interesting results from this, which is the severity of polydipsia in these 2 different groups. So on the y-axis is the owner's report of the severity of polydipsia on a scale of 0 to 100. So 100 would be the worst possible polydipsia that you could imagine. 0 would be no polydipsia at all. And as you can see, 3 weeks into the treatment, polydipsia was pretty bad. And I think that's what you'd expect in most cases that you treat with prednisolone for any reason, is that the side effects are very noticeable at that stage. But what we noticed is that improved quicker in the dogs that were getting once daily prednisolone, shown in the red line, compared to dogs that were getting twice daily prednisolone in the blue line. And so what we're comparing in the statistical test is the red dot at the beginning at 3 weeks compared to the red dot at 8 weeks is significantly different, whereas the blue dots are not different to each other over time, suggesting that giving it once daily might be an effective way to limit side effects, especially in dogs that do have quite bad side effects within those first few weeks of treatment. And then the timing of dose. So this is actually not something that we know anything about in dogs. There's been no published evidence at all. But I just thought it would be interesting to show you what the recommendation is if you were a person who was receiving prednisolone. So this is just taken directly from the website of the National Health Service, the UK, health provider. And as you can see here, the standard advice for everybody is that if you take prednisolone, you should do it once a day in the morning, because of the risk of it disrupting sleep, because one of the known effects of prednisolone is to cause insomnia. And this is just something I think that we would just know very little about. I certainly know owners who have said that they feel that the dogs have been very restless and not sleeping well while they've been on prednisolone, but we don't know systematically how common that really is. And I think a lot of owners probably wouldn't know if that were the case, because they wouldn't necessarily know if the dog was awake overnight or asleep. So again, in a dog that's having more severe side effects, there might be an argument for giving it once daily in the morning, as opposed to either twice daily or in the afternoon or evening. And then just a third topic that we often discuss in the management of IMHA relates to the use of antithrombotics. In this case that I'm mentioning here, so 2 days after starting prednisolone, this dog developed dyspnea, so increased respiratory effort, and also became stuporous. And this would actually not be that uncommon in dogs with IMHA. You really feel like you're making progress, the PCV starts to improve, and then all of a sudden you have this very rapid deterioration that you can't explain, which often is associated with respiratory distress and a big change in the dog's mentation. And so what can this be attributable to? In many cases, it's due to thromboembolic disease. So this is just showing here 2 examples. On the left is a CT scan from a normal dog, and you can see, I don't know if my mouse shows up here, but you can see that these circles here are the pulmonary arteries. Clearly filled with contrast material, which is showing up white here. The contrast material has been injected intravenously, and then the angiogram has been made almost immediately afterwards. So you can see all of the contrast material filling the heart here, and then in the vessels, and this is the aorta here. And then this is an example from a dog with IMHA with a pulmonary thromboembolus. So you can see here, this pulmonary artery is no longer lighting up with contrast because it's been blocked by a thrombus. And this would often be the cause of sudden onset respiratory distress in animals with IMHA. Thromboembolic disease is a major cause of death in IMHA, so we don't necessarily think thromboembolism happens in all cases. However, in those that do badly, it seems to be the reason why they're not doing well. And the most common would be pulmonary thromboembolus, but we also see thrombi in the spleen or in the splenic vein, and sometimes also renal infarction. And we very often see cerebral thrombi as well. So sometimes dogs that have an acute onset of seizures or stuporous mentation, it's because they probably had a thrombus affecting one of the cerebral arteries. And as a consequence of that, then in the recent consensus statement that we wrote on treatment of dogs with IMHA, then we'd recommend that all of them would receive thromboprophylactic treatment unless they have relatively severe thrombocytopenia. So this would be aiming to try and decrease the risk of this thromboembolic disease from occurring. Then the question is, what antithrombotic treatment would be most appropriate? And so when we were formulating a recommendation about this, we looked at the pathophysiology of thrombosis in IMHA and also the published evidence. And so we think that probably the most effective way of preventing thrombosis in IMHA will be to give unfractionated heparin as repeated injections. However, that should really only be given if it's possible to monitor the dose that's being given. And this is just what's shown in the figures on the right here, is that on the top graph is the heparin activity in the blood with just a fixed dose of unfractionated heparin of 150 units per kilo subcutaneously, either every 2 or 4 times a day. And as you can see here, at this standard dose, each triangle here is an individual dog. You can see that the vast majority did not reach this therapeutic range, which is shown in the grey bar here. So just giving a fixed dose of unfractionated heparin, it's very common that you probably just won't achieve very much at all because you don't know if it's really achieving what you would expect. On the bottom graph here is a different approach, which is where these dogs had repeated blood tests to check if the heparin activity was appropriate, and then the dose of unfractionated heparin was adjusted to try and bring it up into this grey range or above. And when this was done, these dogs had a significantly greater survival compared to the dogs that were just administered the fixed dose of heparin, which is why we think that this approach of heparin that's individually adjusted would be the best way of trying to prevent thrombosis in dogs. The difficulty is it's just not very feasible because there are not many centres that have that capacity to measure heparin activity. In fact, in most cases, it's only available in human hospitals. So other approaches that can be considered would be to just give low molecular weight heparins. So this would be things like enoxaparin or deltaparin. Or more recently, there's been talk about this oral factor 10A inhibitor that works in a very similar way. The difficulty is that we just don't know how reliable the pharmacokinetics of these drugs are in the context of IMHA. So again, are they actually achieving anything, or are they just things that we're giving for a good reason, but actually not achieving very much? And so what we think would be probably more feasible in most cases in general practice, and even most cases in specialist practice, would be to think about giving an antiplatelet drug. And of those, we know that clopidogrel is more effective than aspirin. So about 30% of dogs which are given this relatively low dose of aspirin, it just doesn't achieve anything at all in terms of platelet function. And so clopidogrel, given at a dose of between 1 and 3 mg per kg per day, is probably the most effective and reliable way of achieving thromboprophylaxis in a way that doesn't require all of these monitoring tests and precautions associated with heparins. So yeah, that's a summary of what I was talking about here. So low molecular weight heparins, there's good evidence, but they're not easy to use, and they require a great deal of monitoring. And there is also the potential risk of them causing hemorrhage if the dose is too high. However, antiplatelet agents are safe and widely available. I expect that most of the practices you work in would stock clopidogrel that you use for cats with heart disease and other problems. And we know, as I say, that that's more effective than aspirin, and actually easier to dose because it's quite hard to give a low dose of aspirin because you usually need to crush up the tablets and dissolve them. So in summary for what I've talked about today in all of the sections, then I think I've shown at the beginning that diluting our in-saline agglutination tests with a greater volume of saline improves test performance for agglutination and means that we have more confidence in our negative results, but also should be able to pick up most of the cases that we might be concerned about. I think I've shown that glucocorticoid treatment can be optimized by just considering some relatively simple factors like how often we're giving it, what dosage we're calculating based on body weight, and also what the total dose is that we're giving, normally trying to limit that to 2 mg per kg per day because there's really very little benefit in going above that. And then for antithrombotic treatment, it's a really important thing not to neglect because actually we have some evidence just from a questionnaire that we distributed in first opinion practice that actually probably only about 25% of dogs which are in first opinion practice receive any antithrombotic treatment at all. And it would be a very simple way of improving the outcome broadly in those cases is for them all to receive an antithrombotic drug. And in most cases, if that's clopidogrel, it would not be something that we would think would cause any risk for the patient, but could actually do a great deal of good in preventing those antithrombotic episodes. So I'd be very happy to take any questions about this or any related topics. And then, as was mentioned before, for more information, there's this QR code or contact details here.
Thanks so much, James. We've had some feedback on the chat saying that was brilliantly presented. So thank you so much. We've had a couple of questions come in. So the first one was, is there any relation between IMHA and other immune disorders like ATP and hypothyroidism?
Basically not as far as we know. We often sometimes see some groups of autoimmune diseases present together. So for example, dogs that have immune-mediated thrombocytopenia or polyarthritis will sometimes then develop one of the others like IMHA or IMPA if that's not what they had initially. But I don't believe that there's any known association between that and ATP or hypothyroidism, at least in dogs. In people, then there are some associations. So for example, autoimmune hypothyroidism, which is Hashimoto's disease, is associated with a much higher risk of other autoimmune diseases in people, but most cases of hypothyroidism in dogs are not the same pathology. As far as I know, there's no association described.
Great, thank you very much for that. And the next question is, I thought dogs had a natural steroid high in the morning and cats in the evening, and that's directed for me. That's directed for me when I give Preds.
Yeah, this is something that's been discussed as if it was a certainty, a great deal. So yes, you encounter that statement, I would say, quite frequently in talks or books and things like that. But as I say, I looked extensively at kind of what all the evidence for that was based on. And really, I'm not confident that that's definitely a phenomenon that is consistent and which is demonstrated across all the studies which have looked into this. So it is true that there have been a couple of descriptions showing that, but it probably also varies according to what the dog's routine is. So, for example, I believe the study that showed that this kind of idea of a natural steroid high was in experimentally housed dogs that had a particular routine where morning activities were part of their routine. That could have been an explanation for this higher concentration of cortisol. And when this was looked at kind of normal client-owned pet dogs, the same thing was not seen consistently. So as I say, I'm not convinced that that is a fact about the kind of natural steroid high. It possibly depends more on what the routine for the animal is, more than just, all having the same pattern.
Great, thanks for clarifying that. And it sort of follows on, actually. Someone asked, would you mind just reiterating about how to dose prednisolone again?
Yeah, so for a newly diagnosed case of IMHA, then I would typically start at a starting dose of 2 mg per kg per day of prednisolone, and then try to taper that dosage over the following period, really depending on how well they responded and what the side effects of the dog might be. So the general rule of thumb that we would think about is to try and decrease the dose of prednisolone by 25 to 30% every 2 to 3 weeks. But the reason for having that kind of that range of 25 to 30% or time range is because it depends a bit on how well they're responding. So if you had a case that never had very bad anemia, let's say presented with a PCV of 25%, responded immediately to treatment within the first week, and also had some side effects, then I would think about trying to decrease at the higher range of percentage and more quickly. Whereas if I had a dog that was very refractory to treatment, so presented with a very low PCV, took a long time to come up again, then I would probably try and decrease it more slowly and more cautiously, because I'd be worried about then having a relapse later. And personally, I generally would give prednisolone once a day. At the moment, as I say, there's nothing published in dogs to say, should it be morning or evening? What's the kind of actual outcome in terms of the side effects or effectiveness that the dog might have? So I don't think there would be enough information to give a concrete recommendation about that. But as I say, the suspicion, at least from kind of other settings, is that maybe in the morning might be a better option. Oh, I think you're muted, Kate. Sorry.
Oh, sorry. Thank you. Do you also give sucralfate or another GI protectant in addition?
I would certainly think about it in hospitalized dogs which are seriously ill. So in those cases that come in a collapsed state or reduced mentation, off their food, very often dogs with IMHA will have some vomiting or other evidence of gastrointestinal upset. And in those, I would think about giving a gastroprotectant, more normally omeprazole, often just because it can be given intravenously and therefore it's a bit easier in dogs that are not appetent. But I don't think that there is an indication for giving that as a kind of long-term medication for dogs that do have that are just on steroid treatment. So I think in the past there have been a few recommendations floating around that dogs should stay on a gastroprotectant for the whole duration of their treatment for IMHA, and I don't agree with that because I think it's probably unnecessary after the acute period of disease. As I say, in a hospitalized dog that's unwell, I would give it for the first 1 to 2 weeks, but then probably not after that.
Great, thanks. And someone's asked, what would you use as a second-line agent?
It's a difficult question to give a definitive answer to because, again, it's just something where a lot of things have been done and tried, but it's hard to know which of those would be most effective. So the options which are available for a second agent are azathioprine, cyclosporin, or mycophenolate mofetil. I've used all three of them, and my personal experience is that they basically all appear to be, relatively equally effective to each other. But my selection of which one to use might be guided a bit by the particular dog at hand, because some of those drugs cause side effects that I might want to avoid in particular cases. So, for example, azathioprine may cause hepatotoxicity, so I would avoid it in a dog that had known liver disease or which had a very high ALT on biochemistry, which we sometimes see. And equally, mycophenolate mofetil, one of the common side effects that we see with that is gastrointestinal upset and sometimes quite severe diarrhea. So if the dog is presented with any of those problems or has a history of gastrointestinal problems, maybe I would try and avoid that one. On the question of would I always give a second drug or not, then I don't think, again, that there's a right or wrong answer. I think that just starting off giving prednisolone on its own in the majority of cases is fine. I often do start a second drug at the same time, but not because I think it's going to be more effective, but because I think that it probably will make it easier to try and decrease the prednisolone dose over time and have fewer side effects compared to just using prednisolone on its own.
Fantastic, thanks. That's actually, we had a few questions along the theme of secondary drugs, so I think you've answered those there. Someone else has asked if you mind just repeating the dose of clopidogrel.
Yes, so 1 to 3 mg per kg once daily.
Brilliant. And then we have a question of, do you rely more on the saline agglutination test than a Coombs test to diagnose IMHA?
I suppose it depends a little bit on the case. So if it's a case that presents with many classic features of IMHA, so again, you know, what I described before, if it's a Cocker Spaniel, young to middle-aged, and it has a strongly positive saline agglutination test after appropriate dilution, and especially if it has other features of IMHA like spherocytosis and a blood smear, then yes, I'd be confident that you wouldn't need to do any other tests. I think that there is a growing place for doing Coombs tests more often, because I think what we often find is these kind of equivocal cases presenting that don't have very marked saline agglutination. Maybe they don't have spherocytosis on a blood smear and don't have the kind of classic regenerative anemia. And in those cases, I really would prefer to see a positive Coombs test before committing the dog to maybe 6 months of treatment with glucocorticoids. And the thing that makes a difference with that is that in the last few years, they have produced a point of care Coombs test for dogs. So that's one where you don't have to send out the blood sample to an external lab. You can order in a kit that's very like if you've used the blood typing kits where you just use a few drops of blood and you get the results within a few minutes. There is a very similar kit that's now available for Coombs testing, which means that you can just do it there and then. And I think that really increases your confidence that the dog has got IMHA before you commit it to the immunosuppressive treatment.
Fantastic, thanks for that. Someone said, we had a recent case where a mass was found in the spleen when it was ultrasound. Could this have been an incidental finding, or would this have been the underlying cause?
It's a really good question, and actually a very topical question, because it's something that's a question that comes up all the time in these kind of middle-aged to older dogs. Is there'll be some abnormality in the spleen, either a nodule, you know, or multiple nodules in the spleen, or the same thing in the liver, or a single mass. And the question is, you can't know unless you do something to test it. So in that case, if I did find nodules or a mass lesion in the spleen or liver, I think that would be a strong indication for doing fine needle guided, ultrasound guided fine needle aspirates. And in some cases where there's been a kind of suspicious looking mass on ultrasound and the cytology has been concerning, then we think about going for splenectomy sooner rather than later, both as a kind of diagnostic exercise to find out what it was, and also because if that was the underlying cause, you would be often doing something therapeutic about it at the same time by removing the spleen. So, as I say, it depends, and it's something really that often requires further investigation.
Brilliant, thanks. We've had a question again, sort of going back to steroids. Would you ever consider using a long-acting steroid injection instead of daily dosing?
So in the majority of cases, it depends a bit on the product in question. So for some dogs, there might be a reason why you might prefer to give dexamethasone as opposed to prednisolone. So prednisolone causes some mineralocorticoid effects, so it can cause some volume overload. And in dogs or cats that, more often cats that have underlying heart disease, then there might be an argument for treating them with dexamethasone because it doesn't cause that volume overload in the same way as prednisolone can. And in that case, injecting them every 2 to 3 days with dexamethasone can be a suitable way of treating them. Would I treat a case with depamedrone? Probably not, no, just because it's very hard to be accurate with the dosing. You know, although it's supposed to be a kind of stable release product, then the reality is actually that the amount being released is higher earlier and then it tapers off over time. So it's quite difficult to know exactly what the dog is receiving over time. And I would just be worried that, you know, you'll probably have a high dose at the beginning and a lower dose at the end, and that you might have an issue of just trying to keep an accurate dose.
Great, thanks for that. And someone's asked, in a dog which has IMHA, would you recommend not vaccinating them in the future?
Again, it's a hard one to be definitive about. So again, I would just probably take into account some factors for the individual dog. So I don't think that there is a kind of overall correct answer to this question. I don't think that no dog can ever be vaccinated again, or that every dog should be vaccinated again. What I would say was, if the dog had some suspicions on its first episode of IMHA, so let's say it presented 2 weeks after it was vaccinated with its first episode of disease, then yeah, I'd be quite suspicious that dog might have problems again in future. If it was completely unrelated to vaccination, then I wouldn't be too concerned. And then the other thing to bear in mind is, what's the risk for the individual dog? So what would be more of a risk? So do you live in an area where you see parvovirus or leptospirosis? And if you did not vaccinate this dog, would that be a bigger problem? You know, what's the management of the dog? So is this a dog that's a working dog? Is it very outdoor? Is it coming into contact with places where you'd expect it to possibly pick up leptospirosis, in which case probably vaccinating is worth the risk. What we do know is that there's, for first presentation of IMHA, there doesn't seem to be any association with vaccination. So when people have compared how likely is it that dogs would be vaccinated within the past month when they are diagnosed with IMHA compared to any other dog, then there's no difference. But we don't know that answer for relapse. So it is a valid concern.
Great, that's really interesting. And then this is another question, which is going back a little bit to sort of the start of your talk, a little bit more about IMHA, was regarding Coombs testing. So does a negative Coombs test exclude IMHA, or is diagnosis in these cases on a balance of probability?
Yeah, so I suppose I would think that a negative Coombs test would highly likely exclude IMHA. However, there are cases of IMHA that do have a negative Coombs test. And there are a few things that can affect the results of that. So, for example, if the dog has already received blood transfusion, or if they've been on immunosuppressive treatment for some time, then it's possible that they'll produce a false negative result with the Coombs test. In people, then they say that somewhere in the region of 10% of people diagnosed with the equivalent autoimmune hemolytic anemia are Coombs test negative on diagnosis, but you'd expect that the majority would be positive. So yes, I think I would think that a negative Coombs test would make me think, not necessarily that the dog does not have IMHA, but what other features are there that might be suspicious. So if there was no evidence of spherocytosis, no insulin agglutination, that the anemia was not regenerative, and a negative Coombs test, I think all of that was pointing towards something else apart from IMHA.
Fantastic. Thanks so much, James. I'll hand back over to Katie. I think you've answered that huge wave of questions for everyone. So really, really appreciate it. And I'll pass you back over to Katie.
Brilliant. Well, thank you so much, James. I'm sure everybody will agree that was really interesting, and hopefully you'll take away many useful tips to take back into practice. If you have any more questions, feel free to pop them in the Q&A box. I am going to pop the link for the certificate into the chat box now, so you should see that appear. Also, you can scan the QR code that is on your screen now. So yeah, that just about concludes this session. We'll leave everything up for a couple more minutes so people can get the link for the CPD certificate. And yeah, we look forward to hearing from you all in the future. Hope you enjoyed. Thank you very much.